Everybody. We will give it a couple more minutes. People always are a few minutes late, and we'll get started, I don't know, 4 or 5 after, okay? All right. Hey guys, can y'all see and hear me okay? Yeah, good, okay. All right, we'll give it 1 more minute and then we'll go ahead and get started, okay? All right, let's go ahead and get started. Thanks everybody for coming. Hate to punish the folks who get here early and have to wait, but we always have some stragglers. So, okay, so today I wanted to talk about lupus. I try to pick out things that either I feel like our group in general struggles with, or things that are complex in terms of their physiology. And I think lupus is one of those things that all of us are probably a little bit weak in, or maybe everybody else is really strong in it, and I'm projecting my weakness onto you guys. But I think it's something that we could all probably do a little bit better on. So let's talk about lupus. So this is the original title of my lecture, and then it kind of slowly morphed into this. Which is a little more inclusive. All right, so I've got no financial disclosures, and these are our objectives. Basically, we're going to talk about the epidemiology of lupus and how different predisposing factors may influence your risk of getting the disease. We'll go over different aspects of the immune system and how they play a role in lupus. And then we'll talk about the clinical manifestations and the diagnosis, and then briefly kind of touch on some basic management principles, okay? All right. Okay, so usually I like to start out with a case. I'm going to skip that this time because I wanted to talk briefly about the history of lupus, which is not really clinically relevant, but I thought it was interesting. So, a lot of rheumatic diseases are really difficult to say, but at least most of them make sense. Like for example, eosinophilic granulomatosis with polyangiitis tells you exactly what's going on. And so it's well named. These other diseases are also well named, and as long as you know the root word of the disease, you could probably figure out what's going on. Lupus, though, never quite made sense to me. systemic obviously means something we all understand, and we know what erythematosus means, but it doesn't really tell you what's going on with the disease. So it's not near as intuitive as a lot of other conditions. So when I first started preparing for this lecture, I just wanted to read about the history of the word. And so apparently the word lupus comes from the Latin word for wolf. And I guess doctors in the 13th century thought that the malar rash that these patients present with looked like a wolf bite. Which kind of seems like a bit of a stretch to me. I've treated several dog bites, and I imagine they're similar to wolf bites. I've never once mistaken a lupus patient for a patient of mine who has been bitten by a dog. But to satisfy my curiosity, I even Googled dog bites to the face, and pretty gnarly, but nothing that looked like a malar rash. So I'm not really sure how they made that connection. But anyway, the 13th century is when it was first recognized as a disease entity. And then for several centuries, most of the doctors at the time thought it was strictly a dermatologic disease, which made sense. That's what they could see at the time. And it wasn't until the late 19th century until it started to become more clear that it was probably a systemic disease. And the famed internist, Dr. Olzer, was the first one to really put all this together and realize that all these different dermatologic manifestations were a part of the syndrome related to all these other symptoms that we see in lupus. So he linked it to the rash, the arthritis, fever, weight loss, anemia. Pretty impressive at the time, given their limitations and diagnostic tests. And then the world really changed in the mid 20th century when immunofluorescence was invented, and we were able to discover antibodies. And that's when the world of rheumatology and autoimmunity and immunology really took off. So when immunofluorescence was discovered. So anyway, as a quick detour to begin the presentation today. So let's talk about who gets lupus. Basically, anybody can get this disease. Now, classically, it's going to affect African American women in the 3rd or 4th decade, but anybody can get it. Okay. The incidence is higher in adults, it's higher in females, and higher in African Americans. But even though just about anybody can get the disease, 90% of the cases can be are explained by women of childbearing age. Okay. Let's talk about why that is. So there are a lot of different predisposing factors that can put you at higher risk for developing lupus. So one of the most prominent factors is genetics. So long before we even really knew what a gene was, scientists noticed trends in heritability. So even before we discovered DNA, we knew that there was a 35% concordance rate among twins who had lupus. If you had a first-degree relative with lupus, you were 17 times more likely to have the disease compared to the general population. If you had a sibling with it, you were nearly 30 times more likely to have the disease. So we were able to put all this together before we started looking at the genome. But then, in the 50s and 60s, when we started going down that road, we realized that most of the genes that are abnormal in lupus are located on the X chromosome. Okay, and we'll talk about why that's relevant. And the other thing that we were able to figure out is that the genes that are affected in lupus are the ones that encode for proteins that make up the complement system and antibody receptors. Okay, and we'll circle back around to that too. So genetics, however, only account for about 18% of your susceptibility to lupus, meaning there are plenty of other things at play. One of the other really big ones is hormonal factors. So as we talked about, women are much more likely to have lupus. And not only is that because they have twice the number of X chromosomes, and as I said, that's where most of the abnormal genes are located, the estrogen and progesterone also play a big role in accelerating the disease process. And we don't quite understand that, but we know that that's an important factor. And that explains why lupus tends to get worse in pregnancy. And it also explains the post-pubescent jump in the female to male ratio. So even before puberty, females have about a 3-to-1 ratio compared to males, and that's mainly due to the X chromosome, as I mentioned. But then you throw in the hormonal factors and it more than doubles, okay? So it's just bad luck that these genes are located on the X chromosome, and women happen to have 2, and they happen to have, feminine hormones that really make them much more likely to have lupus compared to their male counterpart. So beyond genes and hormones, other things play a role too. So we all know that UV light is an issue, and it's not that these patients are just sensitive to UV light. UV light actually stimulates their immune system to make more autoantibodies, okay? Viruses also play a role. Lupus patients who have higher titers of EBV tend to have worse disease, and that's probably related to the antibodies which are produced against EBV also tend to attack their own healthy nuclear material within their cells, which we'll talk about. But the point is there's some cross-reactivity in nuclear material in lupus patients and the EBV virus. Drugs, particularly antibiotics, can make you much more likely to develop lupus. And there's actually some literature that suggests that owning a dog makes you more likely to develop the disease. All right, so let's move on to really the meat of the lecture here, the pathophysiology of lupus. Now, confession time, I had no idea what I was getting into when I Googled pathophysiology of lupus. And this was my immediate reaction after I saw the first round of Google results. I was like, oh my God, why did I choose this topic? This is incredibly complex, okay? And then this is my reaction for the rest of the time that I was trying to put this slideshow together, just so much regret. And I wanted to go back and change it to an easier topic like gout or something, but I was already in too deep. So, but then the more I thought about it, I had an epiphany, and I realized that the reason that a lot of us are probably scared of lupus or other rheumatic disease is because we don't really understand what's going on. And so I thought maybe let's dig a little bit deeper into the basic sciences than I typically would to help us understand the disease a little bit better. After finishing up preparing for this, I did feel a lot better about lupus, but it was quite daunting at the beginning. So, okay, so before we can talk about the pathophysiology of lupus, we need to review a few immunology concepts from school, okay? So concept number 1, let's review innate immunity versus adaptive immunity, all right? So we have a large complex immune system made up of a lot of different components that you can see there, a lot of different cells that all have their own individual roles and responsibility. But it can mostly be broken down into these 2 big groups, okay? Your innate immunity are cells that will attack foreign material just because. They don't have to have any memory of these cells. They don't have to have any specific receptors. They're just there to beat down the bad guys. So you can kind of imagine the innate immunity as the bar bro who will fight anybody, anytime. You step on his toe, he's going to punch you. You spill your drink, he's going to wrestle you to the ground. So that's what your innate immunity is like. Your adaptive immunity is more like the Terminator. Okay, so he's slow, methodical, only has one target. These are B cells that make antibodies to very specific antigens, or T cells that have very specific T cell receptors. They're both sides of the immune system are equally effective, but they go about it differently. Okay. All right. Concept number 2, apoptosis. So remember that apoptosis is programmed cell death, and it's classically contrasted against necrosis, which is unprogrammed cell death. Okay. The main difference here is that with apoptosis, you have a regulated systematic destruction followed by consumption of these cell fragments by macrophages. Okay, so you have this healthy cell that at some point decides he no longer wants to live, and you start having a lot of condensing within the nucleus, and then you have these little blebs that break off that are ultimately consumed by usually macrophages, okay? And this is an important key to point out here in lupus. If you don't have this phagocytosis ongoing, then these cellular remnants can damage nearby cells, okay? And that's what happens in necrosis, okay? So with necrosis, which is what this picture is showing here, not only do you have the primary insult, ischemia or infection, since this is unprogrammed cell death, as the cells die and spill their guts, they harm all their neighbors, okay? So that's necrosis, whereas this is more apoptosis. So obviously the picture on the left here is fake, but embryos that are in the womb have webbed fingers and toes with skin between the digits, and through apoptosis, you come out with these nice, beautiful hands, okay? So that's the difference between the two, and we'll talk about why that's relevant. All right, third concept that we need to review before going on into lupus is the complement system. So I'm not going to go into depth here. It's really just kind of a reminder. So you have this foreign pathogen that has antigens on it that invades the body, and immune system, or your antibodies are the first parts of the immune system that go after it. And then through this cascade pathway in the complement system, starting with C1, going all the way through to C9, long story short, you get lysis of the invading pathogen, okay? All right, keep that in the back of your mind. All that will become relevant as we move through this. Okay, so the pathophysiology of lupus, there's a lot going on here, but really you can organize it down into two big areas that are not functioning like they should, okay? So apoptosis is dysregulated, and your T cells don't work like they're supposed to, okay? So let's go through each one of those and see how that can lead to problems in lupus. So here's our apoptosis cartoon again. Now, what I didn't mention the first time we went through it, for these fragments, okay, these are all cellular remnants of these healthy cells that have broken down. For these to be consumed by the macrophages, they have to be covered in the complement system, okay? So if we go back to our complement system, the problem here though, in lupus, there are multiple deficiencies or mutations in the complement system, okay? Specifically C1, C2, and C4. As I mentioned, these are located on the X chromosome, and most of the genes affected in lupus help make the complement system. So if you have a defective complement system, the complement can't go and hang out on these little blebs or bodies, and therefore you don't have phagocytosis, okay? So what results there is that as these blebs hang out longer than they should, the body ultimately sees them as foreign, and even though it's our own cellular material, it's interpreted as being a foreign cell, and therefore we start producing antibodies against our own cells. Okay. Now, yes, there's antibodies. Now let's back up a little bit. What are these blebs made of? Now, most of the cell's mass is made up of cytoplasm. But after cytoplasm, the next most dense part of the cell is the nucleus and all the nuclear material. So these antibodies, which are now attacking all of this material hanging out, are being produced against nuclear material. So you're having the production of anti-nuclear antibodies. Okay, so that's where we get a lot of our antibodies that we test for in lupus. So anti-nuclear antibody, the anti-double-stranded DNA antibody, anti-histone antibody. Histone helps hold DNA together. So all these antibodies that we test for all the time without really thinking about what they're doing, these are just where within a lupus patient, they are recognizing these apoptotic blebs as foreign material and therefore producing antibodies against their own DNA, okay? Now the complement system, not only does it help promote the phagocytosis, it also is really important in clearing immune complexes, okay? So remember, immune complexes are made up of an antigen and an antibody. And this is usually cleared out of our system through the complement system. Now, in lupus, the antibody most commonly is this anti-nuclear antibody. The antigen is usually the cellular or nuclear material. And then you have these immune complexes that are forming, but they can't be flushed out, okay? And so these complexes are large, they're large masses of protein that then go and set up in healthy tissue, usually the kidneys, and can cause a lot of damage that way, okay? So let's review all the consequences of a dysregulated apoptosis, okay? So if you can't perform apoptosis normally, which is the big problem, one of the big problems in lupus, you have all these other problems, okay? So first of all, your B cells are gonna assume that these remnants are foreign, and therefore they're making antigens, they're making self-antibodies, auto-antibodies to self-antigens. And not only do they attack the cellular remnants, they now go on and attack healthy cells, okay? This also, defective complement pathway ends up activating more T cells. And so they're releasing a whole bunch of pro-inflammatory cytokines. That happens a different pathway that I'm not going to get into, but it's directly related here. And not only are we making antibodies and are we activating our T cells, you're having this abnormal deposition of immune complexes in healthy tissues, okay? So just having defective apoptosis leads to a lot of these pathways, which ultimately result in the immune system attacking healthy, normal tissue, okay? So that's really only one big pathway, dysregulated apoptosis. So let's talk about T cell dysfunction. That's the other big problem in lupus. So before we talk about T cell dysfunction, let's talk about T cell function. There's actually a lot of different types of T cells, but the two that we focus on the most are T helper cells and cytotoxic T cells. So the T helper cells mainly produce cytokines, okay? And the cytotoxic T cells are the ones that release granules to kill cells, okay? Now, in lupus, the problem here is that the pathway in which T cells are activated is totally rewired. Now, it has to do with this SYK protein, which I'm not going to get into, but the point is, what happens is that T cells have a much lower threshold to be activated and either start releasing cytokines or start killing cells than compared to normal T cells. And not only is there a lower threshold for them to get excited, they also get excited to tissue that should be recognized as normal tissue and not foreign. This graph here on the left is looking at the influx of calcium into T cells, and long story short, calcium is what initiates the T cell cascade that ultimately results in either granules being released to kill cells or cytokines being released. But you can see in lupus, there's this really intense influx of calcium. And so the T cells are just really, really hyperactive in situations where they shouldn't be. If you came to the lecture last time in toxic shock syndrome, had a similar pathophysiology. Now, it wasn't exactly the same, but just through super antigens, it led to this massive, massive T cell response, okay, compared to normal antigens, which is this tiny baby response. So summarizing the problems due to T cell dysfunction, basically you've got T cells destroying healthy tissue when they shouldn't be, and you got T cells releasing all the cytokines when they shouldn't be, okay? So if we put all that together, if we take our apoptosis dysregulation and our T cell dysregulation, it really comes down to four big areas within the immune system where lupus patients have issues. So they're producing cytokines at a much higher rate, and when they're not supposed to, they're making antibodies to their own healthy tissue. Their T cells are attacking their own healthy tissue. And on top of all that, they can't clear these immune complexes, and so now they're essentially causing like a mass effect on the cellular level and destroying the kidney and the brain. And so that's the pathophysiology in a nutshell. So to kind of summarize it in a statement, a good way to look at it would be, so the lupus pathophysiology involves abnormal immune system activation, okay, so it's being activated when it shouldn't be, leading to autoantibody production. We're making antibodies against our own body, and immune complex deposition, which ultimately can target any organ, okay? And then to summarize in pictures, everything that we talked so far is really summarized nicely in this picture. So you have a variety of different factors that all play a role here in lupus, whether it's genetic, environmental, or hormonal, or immune-related, and all that together is going to result in cytokines being produced when they shouldn't, T cells getting excited when they shouldn't, antibodies being formed against our own healthy tissue, and immune complexes being left to set up shop wherever they want. And all those things together ultimately leads to damage in healthy tissue. Okay. All right, I wanted to briefly talk about antibodies a little bit more, and then we'll circle back around to this when we talk about diagnosis. So all the antibodies in lupus are there for a reason. If this was in a classroom, I'd ask you guys to tell me if you knew what all these antibodies here have are related, or how they're related. And all these antibodies that we check in lupus, this is all antibodies to that nuclear material that we were talking about that occurs naturally through apoptosis, but in these lupus patients, they can't consume it because the macrophages aren't activated by the complement. So these aren't just magical antibodies that came out of nowhere. These are just antibodies to different parts of the DNA, different parts of the genome, different parts of the other nuclear materials. Now, of course, we have other antibodies in lupus, and this too is related to inefficient apoptosis. So these antibodies here that we often check in antiphospholipid antibody syndrome, these are all antibodies that are formed against the cell wall. Okay? Remember, from biochemistry, the cell wall is made up of this like double phospholipid layer. And in lupus, you just have antibodies toward that. These healthy layers that are these healthy molecules that should be consumed, lupus patients are forming antibodies to it. And then we have a whole bunch of antibodies, and we never check these, but we could. And these ultimately come down to just antibodies that are attacking other parts of these cells that aren't being cleared properly, okay? As a reminder, ANA is very sensitive. It's not specific, okay? We'll come back to that, but I want to point it out. Your double-stranded DNA and your Smith antibodies, on the other hand, are highly specific, okay? All right, so let's talk about clinical manifestations. So lupus is characterized by alternating periods of remission and exacerbation and a wide variety of signs and symptoms that can affect any organ. So essentially, this is a really unpredictable disease. The key words to highlight here is that it waxes and wanes, okay? Huge variety of how it may present, and it can affect any organ. Now, when it comes to how the disease actually manifests, you generally break it down into two big categories: constitutional signs and symptoms and organ-specific signs, okay? So constitutional symptoms, virtually all these patients have fatigue. Now, not only is this related to disease activity, diseases like this are highly catabolic and by themselves can cause fatigue. But there's a lot of other factors at play here. These patients are often depressed, they're often stressed, they're often anemic. A large portion of them have coexisting fibromyalgia, and so they have lots of reasons to be fatigued. Same with fever. It can be a presentation of the disease itself, like a rheumatic or immune type fever, or it may be related to an infection that they have, or adverse drug reaction. And then weight changes. So like with a lot of other autoimmune conditions, prior to diagnosis, these patients often are losing weight because of that catabolism that I talked about, because of anorexia. But then lupus patients can also have weight gain. Okay, so this can come from the steroids, or maybe they've got lupus nephritis, and so this massive proteinuria, and so they're holding on to a lot of extra fluid. So there's a lot of different ways that constitutional symptoms can arise, and they can be due to the disease itself or other related factors. Okay, so I want to kind of quickly go through some other symptoms, but I'm going to go through this fast because basically you can take any part of the body and just add the word itis to it, and lupus can probably do it. It virtually affects any part of the body. Okay, so I'm really just naming body parts and adding itis at the end, but we'll go through a few and show a few examples. So probably the most common symptom in this in this disease is musculoskeletal. Okay, so that's usually along with the constitutional symptoms, musculoskeletal symptoms are usually the first manifestation. And it's not just in the joints, but it can also affect periarticular structures, so tendons and cartilage and ligaments. One thing to note here, though, is that arthritis in lupus is non-erosive. Okay, I'm going to show you a picture of that, but that's very different than a lot of other rheumatic diseases, such as rheumatoid arthritis and psoriatic arthritis and ankylosing spondylitis. All these other autoimmune types of arthritis usually cause joint destruction, but that's not the case in lupus. Okay. Now, keep in mind, there are some patients who have an RA lupus overlap, and so that's not always the case. But in general, it's a painful but non-erosive arthritis. Okay. They often have pretty bad myopathy, mainly in the shoulder girdle and the pelvic girdles. And then, of course, they can get osteonecrosis. So if you look at this picture, the first thought that would cross my mind is this somebody who's got bad RA. But if you look closely at the joint spaces, they're all preserved. Okay, so there's no joint destruction here whatsoever. So again, this is a non-erosive arthritis. And all these deformities that you see is not due to joint destruction. It's due to these periarticular structures being affected. So mainly lax ligaments and tendons just cause the joints not to be held together very well. Okay. So renal involvement is pretty common. About half the patients with lupus will have some type of renal involvement. And lupus nephritis is a really significant cause of morbidity and mortality. There are a lot of different ways that lupus can affect the kidneys, but most commonly is glomerulonephritis, which is essentially just inflammation within the glomerulus. Okay, but that can lead to destruction of the glomerular basement membrane. It's a lot of protein loss, which is going to result in edema, hypertension. These patients will have red cast and white cell cast within their urine. And as I already mentioned, double-stranded DNA is highly specific for lupus, but it's even more specific for patients who have renal involvement. So virtually any patient with lupus nephritis will be double-stranded DNA positive. So skin lesions are pretty common. Occasionally, it can be the only manifestation of lupus. You know, classically, you see the malar rash. Now, it's really, really important to note the sparing of the nasolabial folds here. Okay, now, this rash is photosensitive. It's usually painful. It's usually itchy. Okay, but it virtually always spares the nasolabial folds. Discoid lupus is another common presentation of skin involvement. So these lesions are erythematous, well demarcated, sometimes scaly. They're often painful and itchy as well. Occasionally, if you have a bunch in the same area, they can merge over time and actually become hypertrophic and malignant. Okay, and there's also a pretty big difference in how discoid lupus itself can present. So you have the more subtle presentation like this, and then you have other types of discoid lesions which can look like this. Lupus, of course, can also cause alopecia, which I don't need to show you a picture of, and paniculitis. So paniculitis is a very painful condition in which you have these erythematous subcutaneous nodules, usually on the extremities, but I've seen it on the abdomen too. A lot of different diseases and infections can do this, but this is one of the more common ways that lupus can affect the skin. And then others, so really any other skin condition lupus can do. So we'll fly through a few more of these, but cardiovascular-wise, the most common thing that we see is pericarditis. About a quarter of all patients, lupus patients, will have this. They can get myocarditis, which has a really high fatality rate. They can get Liebman-Sachs endocarditis. Okay, so this is a sterile endocarditis. So it's not an infection. It's where you get these calcified pieces of protein that hang out on the valves and can lead to valve failure or even cause emboli. And even when taking into account all other risk factors, lupus patients are much higher risk for coronary artery disease and peripheral arterial disease. Of course, as we know, thromboses are common. It can be venous and arterial. vasculitis, Raynaud's. Okay. I always like to show pictures of Raynaud's, but again, this is an arterial vasospasms that occur in the proximal part of the digits that usually is a response to cold. And as the arteries clamp down, you get pallor downstream, and then eventually you're going to get cyanosis from the venous blood pooling in the digits. And then lastly, as the spasms release, you get blood rushing back in. It's painful, and they turn bright red for a few minutes until things kind of regulate again. Okay, so I don't have a picture of the erythroderma, but you know, you get the classic red, white, and blue with Raynaud's. So this is one thing that I didn't realize, that nearly a third of all lupus patients will have seizure disorder. Okay, that's the most common neurological manifestation. They also are at really high risk for stroke, and this can be due to a lot of different things. It can be, you know, thrombotic disease, if they've got antiphospholipid antibodies. It can be, you know, cerebral blood vessels can become inflamed from vasculitis, or they can throw emboli from the Liebman-Sachs endocarditis. A lot of different ways they can get, they can have strokes. And of course, it can affect the peripheral and other parts of the central nervous system. And this can be a direct effect where the disease affects the nerves, or it could be a situation in which the blood vessels that are supplying blood to the nerves get affected with vasculitis, and you have nerve death from ischemia. So lupus psychosis can be a pretty severe psychiatric manifestation, and often is very hard to treat. And as I mentioned, these patients are often depressed, often have anxiety. They commonly get oral and nasal ulcers, and unlike some of the other skin lesions, these are usually painless, and patients often don't even realize it. These are found by physicians. Okay. The eye can become involved. You know, the most concerning is optic neuritis or retinal artery occlusion, but other presentations are really burdensome too, you know, like with conjunctivitis or sicca. And I'm just going to fly through these. So the GI system can be affected, and you know, any one of these manifestations within the GI system, all of these can be fatal. Mesenteric vasculitis is often fatal. Protein losing enteropathy can cause severe malnutrition. Pancreatitis is often severe. From a pulmonary standpoint, this usually occurs late in the disease process, and pleuritis is the most common, but other life-threatening manifestations can occur. So diffuse alveolar hemorrhage, pulmonary artery hypertension, pneumonitis, you know, virtually anything on this page can kill you. And then of course they're at high risk of developing any type of ischemia from bone marrow involvement. Okay, so as hospitalists, we often don't make the diagnosis of lupus ourselves, but I imagine there are quite a few patients we have that may have lupus, and we're dismissing it. And I think part of that is because it's not on the front of our mind. And so there's no one easy way to diagnose lupus. So I just wanted to go through a few things to basically tell you how you should think about these patients and when should it be at the front of your mind. Okay. And the fact that it can present in so many different ways makes the diagnosis really challenging. There are some different diagnostic criteria that can be very helpful, but again, you have to know when should I go and consult these criteria to see should I be thinking lupus. So there are actually 3 different criteria systems. The most recent one that came out is not really being used in clinical practice yet, but these 2 here are the 2 most commonly used. And essentially, you've got to have involvement in multiple organ systems, and you've got to have serological criteria to back it up, okay? And for both of them, you just have to have 4. So if you meet any 4 of these, it means lupus is likely, okay? Now, they don't necessarily break it down into clinical criteria and, well, they do break it down in how it's organized, but you could have 5 or 6 of these criteria, but not have the antibodies to back it up, and that would still potentially meet the criteria. Vice versa, you could have the antibodies without the clinical manifestations. And so diagnosis isn't always straightforward. Another way to look at it is this graph here. So as I mentioned, ANA can often be very helpful because it's so sensitive, okay? Now, you don't just order it willy-nilly, but if the clinical history backs up a possible diagnosis of lupus and you check an ANA and it's negative, it's almost always not lupus, okay? It's not perfectly black and white, but the way that I use this graph is if my ears are perked for lupus and I check an ANA and it's positive, that's when I should start going and looking at these other criteria, okay? Again, another way to think about it, basically, if you have any patients that have any of the following symptoms that are unexplained, you need to be thinking about lupus, okay? So unexplained constitutional symptoms, a photosensitive rash, arthralgia, pleurisy, nephritis, seizures, you guys can read. Again, this is a huge net that you're casting out. I'm not saying order an ANA in all these patients, but if you see any of these symptoms, you need to be thinking, hey, am I sure that I've got an explanation for these symptoms, or do I need to be considering lupus? Now, all that said, these diagnostic criteria are not perfect. They're going to miss a lot of patients. So they can be helpful, though, in narrowing your diagnosis into these three big categories. So definite lupus, probable lupus, or possible lupus. But again, that still doesn't get everybody, because you're still left with this undifferentiated MCTD type folks. And then there's a small subset of lupus patients who are ANA negative. Okay, so the whole point of this is there's no great way to go about diagnosing lupus. Just it needs to be something that we're thinking about more often. Okay. All right, management. That's all I got on management. Basically, just call rheumatology. So I'm kidding. You do need to call rheumatology, but let's at least talk about some general principles to help us have an idea of what their thought process is. So there are, big picture wise, there's a few goals in terms of managing lupus. Obviously, you want to keep your patients alive longer, and you want to have the lowest possible disease activity. You're trying to prevent organ damage. You got to be really mindful of drug toxicity, and these patients have a pretty miserable quality of life a lot of the time, and that has to be taken into account when you're trying to figure out treatment options. So lupus is not like heart failure. If you've got heart failure with reduced ejection fraction, got to be on a beta blocker, you got to be on an ACE inhibitor, you got to be on aldactone. Lupus is not like that. Okay, there's no one size fits all, and treatment is going to be tailored to multiple things. It's going to be tailored to how the disease is manifesting, the severity and activity level of the disease, what the patient preference is, how the patient's responded to prior therapies. So there's no one size fits all. What needs to be considered when you're thinking about treating these patients is what does their disease look like in terms of the timeline? Do they wax and wane? Do they have these? Are they usually controlled and then have intermittent flares, or are they always in a flare, chronically active? Or are they, would you have what you call quiescent disease, where it's there and you've made the diagnosis, but it doesn't really manifest itself that often? So a few general principles. Every patient that has SLE should be on hydroxychloroquine, okay? I wouldn't have had second thought to say this if this was 2019, but it's a little ironic in 2020. But if you've got lupus, you need to be on HCQ, okay? It reduces flares, it reduces thrombotic events, and it improves mortality. And then when it comes to tackling other types of patients, it really comes down to, as I said, how severe the disease is. So for patients with mild disease, and usually mild disease is classified into those who just have some dermatologic manifestations and maybe some joint involvement. Again, they got to be on HCQ, and then you can treat these intermittent flares with steroids, low-dose steroids, short-term low-dose steroids, and NSAIDs as indicated. Now, if you've got moderate disease, which is usually defined as widespread disease activity but non-organ threatening, again, they got to be on hydroxychloroquine. Usually they're on a medium dose of steroids. Now, where things get tricky is if they don't respond to the medium dose of steroids, or if the disease relapses when you try to taper that medium dose of steroids, that's when you got to think about adding other types of less toxic immunosuppressant agents like azathioprine or methotrexate. Now, with severe disease, which is life or organ threatening, those patients need to be hit really hard with IV steroids. And most of them are going to need some other type of potent immunosuppressive agent, okay? I think the ones I've seen used the most are cyclophosphamide and rituximab. And cyclophosphamide works by decreasing T cell activity. So that should make sense based off what we learned about pathophysiology. And rituximab is an monoclonal antibody that works by decreasing B cells, and it reduces the amount of antibodies that B cells are making, okay? So again, that makes sense in terms of what we've learned so far. But it's not all just medicines, okay? There are a lot of non-pharmacologic interventions we need to be thinking about in our lupus patients. They got to stay out of the sun. Like I said, it's not just that they're sensitive, it's that it actually stimulates their immune system. Diet, nutrition, and exercise are important for a multitude of reasons. One, if these patients have diabetic nephritis, or if they've got, lupus nephritis, or if they've got a protein-losing enteropathy, they're going to be really malnourished, and they need to have proper nutrition for that. The other thing is, for these patients who are on steroids and who have an increased appetite due to that, they may be more prone to gaining weight. And like with any other disease, obese lupus patients have much poorer outcomes than non-obese patients. So whether they're malnourished or overnourished, we need to be really mindful of that. Get them on vitamin D. They got to stop smoking. As I mentioned, even when you account for all of the risk factors, these patients are at really high risk for coronary artery disease and peripheral arterial disease. So smoking is a big no-no. And then beyond renal failure, the most common cause of death in lupus is infections, okay? And so if they're not properly immunized, they need to be brought up to date there. All right. Okay, a few tips. So I wanted to invite a few esteemed rheumatologists to have a little panel to give you guys some tips of the trade, but none of them can make it. So we had a few other doctors that volunteered to give you some advice. So the first one up is Dr. Emmett Brown. He's not even a physician. He's just an inventor and time travel expert. But he wanted to make sure you guys know that myalgias, arthralgias, and fatigue are not a reason to check an ANA, okay? So ANA is, can be an extremely helpful test, but it has to be interpreted in clinical context, okay? So an ANA in somebody with knee pain is worthless, but an ANA in somebody with hematuria and rash and pancytopenia is highly suggestive of lupus. Okay. The other thing to know about ANA is that it's helpful for diagnosis, but once a diagnosis is confirmed, there's no need to monitor it. Okay, it's not like some of these other antibodies. They do not correlate. ANA does not correlate with disease activity. All right, our next doctor. I think she's a real physician, but she's not yet board certified. But Dr. McStuffins wanted to remind us that fibromyalgia can coexist in up to 30% of lupus patients. Now, why is that important? Fibromyalgia can be a really debilitating disease and life-altering for patients in terms of quality of life, just like lupus. And just like lupus, it can pretty much manifest itself in any way. But what you don't want to do, you don't want to treat fibromyalgia with lupus medication. So just be cognizant of this high incidence of coexistence between these two diseases. Now, one thing that may help will be brought to us by Doc Holliday, who's actually a dentist, but he's pretty familiar with lupus here. And he wanted to remind you guys that unlike ANA, double-stranded DNA antibodies do correlate with disease activity. And your complement, specifically C3 and C4, often get depressed in flares. So these aren't perfect tests, but in patients who have both lupus and fibromyalgia and they come in with a variety of complaints, if their double-stranded DNA is through the roof and you can't detect their complements, C3 and C4 complements, it's probably lupus driving that. Now, if those antibodies or if those labs are normal, it doesn't tell you it's not lupus, but it's just more data, okay? Then we got Dr. Evil. Dr. Evil wanted to tell us that parenchymal lung involvement is not that common in lupus. Okay, so that's parenchymal lung involvement, so not pleurisy, not pleuritis. We're talking about the lung parenchyma. The reason that's important to know is that if you get an X-ray in these patients and you see infiltrates, odds are it's going to be an infection, okay, and not lupus lupus activity. Okay. Okay, and then we have Dr. Watley. Anybody know who Dr. Watley is? If you don't, he was Jerry Seinfeld's dentist, and I asked him to give us some tips, and he said that he didn't become the most premier dentist in Manhattan by just giving us a few tips. So he wanted to talk about an entire topic. So he wants to talk about drug-induced lupus. So drug-induced lupus is most commonly caused by these 4 drugs here. Now, the only one out of those 4 that we as hospitalists use frequently is hydralazine, but we do use that a good bit. So that's probably the most common drug that can cause drug-induced lupus. It's important to know that drug-induced lupus never involves the kidneys and never involves the central nervous system. Okay, so if either one of those systems are involved, then it's probably not drug-induced lupus. For these patients, usually if you stop the drug, they get better. So they don't need, generally, they don't need a lot of potent immunosuppressants once you stop the drug. And then it's important to highlight the antibody profile in lupus patients. So, sorry, in drug-induced lupus. They're going to be ANA positive, most likely. They're going to be anti-histone antibody positive, most likely. But unlike other types of lupus, they will probably be dsDNA negative and anti-Smith antibody negative. Okay. Okay, and then our last tip here is from the medical droid from The Empire Strikes Back, who has a keen interest in rheumatology, and he says that a rash that involves the nasolabial folds is much more likely to be rosacea. Okay, so again, here's our lupus patient. You see the sparing of the nasolabial folds, nice healthy tissue here, compared to a rosacea patient where it's pretty red and erythematous. So it's not a perfect test, but this is pretty specific for a lupus malar rash. Okay. All right, guys, that's all I got. Do y'all have any questions for me about anything we talked about? Okay, so I will send out a link to this this presentation later on, and I'm also going to send out an evaluation survey. I'm going to keep doing these lectures no matter what, but if you guys want to keep getting CME credits, you got to fill out the evaluation link. So it looks like Lori put a link in the comment section there, but that's important for you guys. Doesn't really matter for me, but yeah, do it so you can keep getting credit, okay? If you guys have any questions, please let me know. I've uploaded some lupus articles to the APP development Google Share Drive. There's 3 different ones I put on there last night. They're really good, and they go into depth if you guys want a little bit more nitty gritty. So, all right. So I'm around if you guys need anything. Okay. All right. Thanks for coming.